problem fixed. So we're live on
Okay,
now too.
good.
So I think we can start from our lecture now. So hello to everybody who joined us for today's lecture. My name is Charlie, and I'm president of the research committee of the Psychic Biological Society. It's a great pleasure and honor to have today for a lecture Dr. Costas G, who is also originally from Cyprus. It is a great pleasure to have him. And also, he's one of the top neurosurgeons in the world, and especially in the fight against brain tumors. So before I give the floor to Dr. Hadjipanayis, I'm just going to go through a very brief, as much as possible, introduction for his work, and then we can go on with his talk. So with that said, Dr. Hadjipanayis, as I mentioned, is a board-certified neurosurgeon who has devoted his entire career to the treatment of brain tumor patients. He completed his neurosurgical residency and graduate PhD training at the University of Pittsburgh School of Medicine, with additional neurosurgical oncology training at the University of California, San Francisco. He was recently recruited back from the Icahn School of Medicine at Mount Sinai in New York City, where he served as the chairman of neurosurgery at Mount Sinai Union Square, Bethany Drive, and he was also the director of neurosurgical oncology for the Mount Sinai Health System. He is the L. Dave Lunsford Professor of Neurological Surgery at UPMC and served as the executive vice chairman for the Department of Neurological Surgery. He is also the new director of the UPMC Center for Image-Guided Neurosurgery and also serves as the co-director for the UPMC Brain Tumor Center. Dr. Hadjipanayis directs the Brain Tumor Nanotechnology Laboratory in the Hillman Cancer Center and has been the principal investigator of multiple clinical trials and university, private foundation, and NIH-funded grants focused on brain tumors. He has focused much of his career on innovation, translational research, and intraoperative technology development. In 2011, he was the first to use 5-ALA or Gleolan and perform fluorescence-guided surgery in the US, and also helped lead the FDA approval of Gleolan for glioma surgery in June 2017. In 2024, Dr. Hadjipanayis is launching the first 5-ALA intraoperative photodynamic therapy clinical trial in the US for newly diagnosed glioblastoma patients that will utilize a new drug called Pentalafen. He's currently studying the use of magnetic iron oxide nanoparticles for the targeted imaging and magnetic hyperthermia therapy for glioblastoma multiple. This collaborative and translational NIH-funded research involves Johns Hopkins University, Pennsylvania State University, and in developing a new treatment for glioblastoma. Dr. Hadjipanayis has been a tireless brain tumor advocate, serving on the board of directors for the nonprofit Stash Strong and the Southeastern Brain Tumor Foundation. And with all that, I don't want to delay his talk. I know he's very busy. And again, thank you very much for accepting the invite. And I look forward to hearing your talk.
Thank you very much, Dr. Charlie. That was a very nice introduction. And welcome, everyone. Greetings from Pittsburgh, Pennsylvania. We're going to jump into this. And what I told Maria is if you have any questions, I don't mind if you interrupt me. I'd love to discuss any question or idea you have. Here is the agenda. This is basically a story of mine that has gone on for, over 10 years now. And, we're still going strong. So we're going to talk about some of the unmet needs in neurosurgical oncology. This is a very translational talk, which may be a little different than some of the more basic talks that you are used to, but I think it's important for you to see how these ideas go to the clinic and our patients. So we'll talk about fluorescence-guided surgery and some of the challenges and regulatory pathways we took in the US, and then some new devices we're developing, and then a new theranostic approach we've just launched in the US. So here are my disclosures. I want to start off by just, highlighting my background. So, my father is from the island of Cyprus, and he's from a small village northeast of Bafo named Mesoi. And my mother's from Patra. I was born in Canada, but we love visiting Cyprus every year. We have a family home in Mesoi, and I think it's my favorite place. I would like to say, disclose that to everyone here on this call today. And it's just Cyprus is such a beautiful country, and I know it's had challenges in the past, but it really is a magnificent place that I'm proud to have roots in. So, a couple slides on the importance of translational research before we jump into the meat of the talk. So, why is translational research important? Do we need to do translational research as a physician? Does it have to be benchtop research? How can you be part of high quality and meaningful research? Can you be an excellent physician and researcher? Can you perform research alone? These are some of the key questions that we always ask ourselves. And I truly believe in this concept of translational neurosurgery, which is a form of translational medicine. And, really identifying unmet needs in my practice is what I look at, both in and outside the operating room, and understanding the current limits of what we can do and how we can translate those ideas to patients is very important to me. The mentorship that I've had through the years has been very helpful for me and really helped me guide my research and my clinical practice. I think these are individuals in your institution or outside your institution you can collaborate with for ideas and really kind of putting together a team, because you cannot do this type of work by yourself. The institutional support is important as well. You have to have a culture of research that respects translational research. And in surgery, that hasn't been exactly the case in many centers. You really have to have the department and institution complete meaningful research to allow you to build a team around you that supports the vision you have with students, techs, residents, etc. Okay, we'll come back to that at the end of my talk, but for now, we're going to start some of the background of the area that I'm focused in my practice and my research, and those are called high-grade gliomas. These are the most common malignant brain tumors that originate in the brain. They're not metastatic tumors. They originate in the brain, and in most instances, what we like to do from our end is take them out surgically. And the goal is, how do we do surgery without hurting the patient? And in many instances, we can never take out all of the tumor because of its biology. And then patients go on to radiation therapy with chemotherapy. And then at relapse or recurrence, we consider more surgery, chemotherapy, more radiation, and really haven't made much of a difference in overall survival, which may be around 16 to 18 months for all patients with this terrible disease, despite everything we do, unfortunately. So we haven't made a lot of progress in terms of approval of drugs and devices for high-grade gliomas. And the most common one is glioblastoma. This is the one we hear about in the news. This is the one we hear about that's just devastating. And you could just see here that we've had the same kind of drugs for decades. And really the newest drug that we have is Avastin, which came out in 2009. And then I'll talk to you about 5-ALA, the story. And when we got that approved, it wasn't approved as a therapeutic. It's mainly approved as an optical imaging agent. But now we have some other types of local therapies we could look at, such as Gamatol for recurrent high-grade gliomas, which is a form of a radiation implant. So when I take care of my patients, the number one thing I try to do is take out as much of this tumor so I can make a difference in their overall survival and their ability to complete adjuvant therapy. It's now been well established that the extent of resection is associated with better outcomes. Now, the challenge with glioblastoma is that the tumor has an infiltrative border, and while we may think we get it all out based on MRI scan, you could see here that the contrast is just a part of the tumor. And while we take out the contrast enhancing part of the tumor, we know that there are other parts of the tumor that we don't take out, as you can see here on the right. And that's been well established with these infiltrative high-grade gliomas. That's the challenge with glioblastoma. And the problem is that those tumors almost always recur in that local vicinity of the tumor resection. So how do we see those cells better to take them out surgically? How do we visualize them with imaging to treat them better? So much of my career, I've focused on how we could see these better in the operating room. And I'm going to show you some pictures. Hopefully you're not going to be afraid of seeing some of these pictures. Shut your eyes if you are. I mean, I promise I won't show you very bloody scenes here, but this is just a picture of a cavity in the brain after surgery. And we have tools in the operating room that allow us to localize the tumor so that we can get to it, but they're just not precise as well as they should be for the surgery we do. So there's definitely an unmet need in visualizing tumors during surgery so we can delineate them from surrounding tissue and really feel confident that we remove the right tissue that corresponds to the tumor. And while the tumor here you could see is discolored by the blue arrows, there are cancer cells all in this white area that I can't see well. And that's the challenge with glioblastoma. So fluorescence-guided neurosurgery has, been around now for a couple decades. This is utilizing a fluorophore or prodrug in the instance of 5-ALA that accumulates in the tumor tissue. And then with the right wavelength of light, you can excite that fluorophore that then allows you to see the tumor tissue well and delineate it from the surrounding brain. That allows me to remove the tumor in direct visualization in real time. And this is something that the German group, Dr. Walter Stumer, showed in a randomized study now 18 years ago in 2006, where you could see that the amount of tumor resected with use of 5-ALA fluorescence-guided surgery was almost double compared to the standard conventional method with white light on the left-hand side. And this did correlate with a progression-free survival increase, as you can see on the right-hand side. This trial, however, was limited by some other shortcomings in terms of standardization of adjuvant therapy. Some people got radiation, some people got chemotherapy. So that was a big question mark, but it did pretty much nail down the fact that we could take out more tumor using 5-ALA with direct visualization of the tumor. And the other important point was that we could do this safely. And if you look at the neurologic exam of patients, it was basically the same at 3 months. It balanced out. Well, the French just recently completed a multi-center study confirming the multi-center German study, basically showing that more tumor could be taken out with 5-ALA. This was a randomization trial with the placebo in 171 patients with GBM, and they again correlated greater overall resection with 5-ALA, and they felt that removing more of the tumor was associated with better patient outcomes. This was just published last year. So there are other fluorophores that we've also looked at in the operating room for brain tumors. Today, I'm going to talk to you about 5-ALA, but there's fluorescein, which is excited in the 500 nanometer range and with a yellow visualization color. 5-ALA is excited in the 400 nanometer range and emits at 635. And then ICGs in the near infrared at 805 nanometers. These are just a table. This is a table summarizing some of these other fluorophores being used. 5-ALA is really the only FDA-approved and EMA-approved optical imaging agent for use in brain tumors at this point. Okay, going back to the original picture I showed you with the conventional white light in the operating room, when we gave 5-ALA and then we gave the right light, you could see how the cavity fluoresces violet red, showing us that there's still tumor there, even though we thought we had taken out the tumor. 5-ALA is a very amazing agent in terms of the ability for it to cross the blood-brain barrier, get into tumor cells, and then be metabolized to its fluorescent metabolite protoporphyrin 9. So 5-ALA is not fluorescent, its metabolite protoporphyrin 9 is, which is quite interesting. This is some of the original video from 2011. Now this is, 13 years ago, where we did the first surgery in the US using 5-ALA. And you can see with this low definition video that as we're doing the surgery, as we flip on the blue light, you can see the fluorescent tissue, around the resection cavity. And that shows us the tumor and allows us to take it out in real time and really maximize the resection. So this is something that we did early on. The Germans had did this before us. And the beauty of this is that, again, it's a safe agent. It's excited at the 400, 410 nanometer range. It's non-toxic. You can have skin photosensitivity in 2 to 4% of patients, which is basically a sunburn. It's metabolized by the liver, and the liver enzymes elevate transiently. Okay, how do the tumors fluoresce with 5-ALA? Well, it turns out that in the mitochondrial pathway, the ferrochelatase enzyme is essential for protoporphyrin 9 to convert to heme by the addition of iron through ferrochelatase. Well, in gliomas, the ferrochelatase is lower in number, so the protoporphyrin 9 backs up, and that allows for the selective visualization of glioma cells with fluorescence. We've also, realized that there are other pumps that pump out the protoporphyrin 9 that may not be as active in glioma cells, and there may be, increased uptake of ALA into glioma. So all these types of mechanisms allow for the increased production of protoporphyrin 9 in the standard mitochondrial metabolite pathway that it occurs in patients. So as we began this journey, we were trying to understand how to convince the FDA to understand the importance of this drug that was really not a therapeutic at the time. And what we had come upon at that time was defining clinical benefit with use of fluorescence-guided surgery. And that was something that we were able to show to the FDA that, we could use fluorescence-guided surgery to direct us in real time and delineate tumor and take out tumor and not hurt the patient. And that also the diagnostic accuracy of the optical imaging agent was very high, and that did provide clinical benefit. And that's really the path we took with the regulatory approval in the US, is that we wanted to show that this agent did provide clinical benefit because of its high diagnostic accuracy. So when you saw fluorescence, you could confidently say that that was related to tumor visualization. And this was, basically defined with sensitivity, specificity, positive predictive value, negative predictive values. Now, we all use these in our experimentation, in our research, so they're pretty well known. The challenge with, however, gliomas is that because of their infiltrative nature, the core of the tumor, when we detected fluorescence, was highly correlating with tumor. Now, as we get to the periphery, that fluorescent signal then drops. And you can see here with the orange and the yellow dots that, you basically have a challenge of, having a lower negative predictive value, the further you get out. And, I think part of that is because of the fluorescent signal being lost with the infiltrating cells of the brain surrounding those tumor cells. And the specificity is lower than the sensitivity. So these are some of the challenges that we had to educate the FDA as we went forward. But the beauty of all the studies that we had collected was that the positive predictive value was extremely high with 5-ALA, confirming a very high diagnostic accuracy. Well, we completed the first prospective US multicenter study. This was published in 2021. And this was in 69 patients with new or recurrent GBM. And we also did sampling to really nail down the fact that the sensitivity was quite high and the positive predictive value was quite high. You could see our specificity, however, was on the lower end, and our negative predictive value was on the lower end, as expected. But this was the study that really showcased in the US how effective this agent was as a diagnostic agent in the operating room. And safety was also in line with the European studies. We didn't see anything different, which was very helpful. So we've learned that as we utilize 5-ALA in different parts of the tumor, the solid portion of the tumor is a violet red, and as we move to the periphery, it becomes vague and pink, and then we get to a point where we don't see fluorescence. Well, it's a little bit misleading because in the area where we don't think there's fluorescence, there actually is fluorescence now that we're using newer diagnostic devices. But at the time, the microscopes we're using are very basic and weren't able to detect fluorescence. So I'll get back to that at the end of the talk. We also learned that the margin of the tumor could be detected with 5-ALA quite nicely, and that we could move past the contrast-enhancing border with intraoperative visualization of fluorescence. And there's been some studies comparing this to intraoperative MRI, really nailing this down. One of the other things we've recently learned, though, is that there is a false positive fluorescence that can be noted with reactive astrocytes. Now, one of the things we've also found out is that tumor-associated microglia macrophages can actually take up 5-ALA, and these are associated right at the margin of the tumor, and they are associated with the tumor. So it may be also a little misleading to say these are false positive fluorescence because it's likely related to those cells that are comprising the tumor at the margin. And there's a paper that just came out this year, I need to update this slide, that was published in the Journal of Neurosurgery from the Columbia group showing this. In terms of false negative fluorescence, we've learned that, as we mentioned, our detection devices fluorescence may be unable to visualize fluorescence that's present. Any blood or overhanging tissue could interfere with the fluorescent signal. And then photo bleaching may be an effect that we see. So there are new tools that we're developing to help us, detect the fluorescence better at the margin. So as we were going to the FDA, we really developed a story where we can showcase that 5-ALA is a highly diagnostic visualization agent with very high positive predictive values, but also allowed for maximal extent of resection of tumors based on the randomized multi-center German study and led to better patient outcomes. So you can see here, this is the FDA approval timeline. It took us, basically almost, 6 years or 10 years after the EMA approval of 5-ALA to get it approved in the US in June of 2017. And now it's pretty much used as standard of care in high-grade glioma surgery. This was a team that we went to in 2014 at the FDA. On the right is Walter Stumer. On the left is George Widhelm. He's in Vienna, and Walter's at University of Munster. And then this is our day at the FDA when we got the approval from the advisory committee. These are some of my colleagues. So we've moved on from there, and fortunately, we were able to get this into our patients, and it's now being routinely used. Now, there are some challenges still. I wouldn't say this is as prevalent now, but it's, some adoption is still not unanimous by neurosurgeons. And there are some needs for paying for a special microscope that has a modification. And, the cost of this is also significant. It's $2,500. It's probably over 2,000 euros in euros. And you do have to administer it, several hours before surgery. So, if you look here, these are some of the other tumor types we're exploring it and what it's approved for. And now we're going to soon talk about another indication for use of 5-ALA. The use of 5-ALA has also been very helpful as a biomarker for anaplastic foci and lower grade gliomas. You can see here that if you give it in a non-enhancing tumor, you could detect patchy areas that could be malignant. And we know these tumors have areas that are of higher malignancy in different parts of the tumor. Meningiomas are a different tumor type that we are now looking at. These are benign tumors overall, but they are highly fluorescent. You can see here, this is a recurrent meningioma. Again, sorry for the blood in the view here, but you can see that with fluorescence, these things can light up quite nicely. And we can actually use this to detect residual tumor, in the cavity as we turn on the blue light. Okay, so the pediatric tumors are ones that I'm personally interested in, and we're very close to launching a pediatric multi-center study in the US that I'll be leading. I'm not a pediatric neurosurgeon, but I have friends who are pediatric neurosurgeons. So, we are very close to launching this. This may have a better impact than adult patients, since we know these patients do better with more resection. Some other cancer types that 5-ALA is being explored now is with head and neck cancers. In New York, we did this first case and published this in Laryngoscope. Highly fluorescent tumors with head and neck. Some points about the timing in terms of when we give it and how long we should wait. We've learned that the longer we wait, the better it works and accumulates inside the tumor tissue quite nicely. And even 24 hours later, we could see this. This is at Henry Ford University in Michigan. So I'm going to switch gears a little bit. One of the other things that I enjoy doing is also technology development in terms of visualization devices. So, in the operating room, I've been using this device called the exoscope. It's a newer way of operating by using a camera at the side of your head or shoulder to magnify into the cavity to visualize the surgical field on a high definition monitor straight in front of me. And this allows me to kind of visualize the tumor and then perform the surgery in real time. Well, we've done new things now with fluorescence-guided surgery to really see how well this works in comparison to our more conventional visualization methods. And the lighting has allowed us to detect better fluorescence. The working distance is even longer with the exoscope. So there's all sorts of benefits now we're uncovering with the device that we're using to really understand, how fluorescence appears. This is a tumor that we're removing. In real time, you can see here, this is a recurrent tumor, and the fluorescence is really helping me understand exactly where the tumor is in the brain. Well, the other thing we're interested in developing are handheld devices to detect the tumor better, in addition to the primary visualization devices. And there's been a fair amount of work done looking to see if fluorescence can be detected in what we call lower grade tumors, low grade gliomas, and they do accumulate protoporphyrin IX. So that's something that's quite interesting. We've been working on a new handpiece where we can bring the blue light right up to the tumor and highlight the tumor well with the device in order to detect the tumor better. This is almost like a flashlight for protoporphyrin IX after 5-ALA is administered, and it really enhances the visualization of the fluorescent tissue quite nicely. I think I have a video here where you can kind of see it's a blue flashlight. You can see how it just really highlights that fluorescent tissue quite nicely, so we could do surgery better. This is just more video again, highlighting it in areas that we don't see it well with the conventional microscope, but then with the NICO, we could see it quite nicely. And we're doing some histopathology studies to really correlate that fluorescent signal with tumor tissue so that we know what we're seeing represents tumor. Okay, so just briefly, intraoperative MRI has been compared to fluorescence-guided surgery, and they both perform quite well, and there's really no method that's better than the other. So I think, that's something that we can use together if we have the means to do that. It's very expensive to use an intraoperative MRI in some centers. I'd like to kind of now shift to the latter part of my talk. So we've talked about 5-ALA as an intraoperative optical imaging agent so we can visualize tumor with high diagnostic accuracy. Well, it so happens that if you excite the protoporphyrin IX with a different wavelength of light, 635 nanometers, you can actually kill tumor cells in the vicinity through reactive oxygen species. And if you look here, this is a video demonstrating the use of photodynamic therapy with light targeting the cancer cell. Remember, 5-ALA accumulates in the tumor cells and the tumor-associated cells. So it's a nice selective targeting agent that, if utilized properly, could target the cancer cells that we cannot take out with surgery. So PDT has been around for quite a long time. I mean, it's been used with photofrin as the fluorophore with other tumor types and cancers. In the brain, it's never really gone far because of the toxicities associated with photofrin. And there's been some preclinical studies looking at the use of 5-ALA PDT and fractionated light to really understand how that helps with the tumoricidal effect in preclinical models. There are limitations in terms of light penetration of the tissue, oxygenation of the tissues, and delivery of the agent to the tumor tissues. A study that was initiated now almost 9 years ago was in the University of Lille in France, where they basically utilized 5-ALA as a photodynamic therapy agent at the time of surgery. So this is a paper that was published relatively recently. I helped with this paper. I did not treat any of the patients. And this was really a pilot study in 10 patients where they underwent surgery and then intraoperative photodynamic therapy with a balloon-paced system. And you can see the balloons placed in the cavity, laser fibers slid through the balloon, and then the cavity is illuminated. And this is a, just an illustration showing this with expansion of the balloon in the cavity and then turning the light on for several minutes, turning it off for several minutes, on and on. And, the light dose, the energy used for the treatment is calculated based on the volume of the resection cavity. So the University of Lille started this study in 2016. Patients were enrolled from 2017 to 2018. And, you can see here in the operating room, the laser light and the goggles. And they basically, enrolled 10 patients. You could see here that, they were able to do the treatment in around 30 minutes for each of the patients. 6 patients died over the course of the study, which was, stopped in 2017, 7 years ago. But 4 are still monitored. I was just made aware that 1 person did die recently of that 4. And so we have 3 out of the 10 as long-term survivors, meaning over 6 years, which is really interesting with glioblastoma. The 4th person was over 6 years as well. They recently died. So actually 4 of the 10 were long-term GBM survivors. 1 of those died recently. So it was quite interesting to understand what happened, in those patients, since the survival is usually 18 months. And we looked at some of the serious adverse events. Overall, very safe for patients, nothing that was notable in those patients. And then when you looked at the overall survival, it was really impressive in terms of what they found in that limited 10 patients of close to 23.1 months. Progression-free survival was actually 17 months, which is really interesting. So these are just some MRIs showing some of the effects of the PDT and good long-term tumor control. We have recently launched the Indigo US study. So this is the first US-based photodynamic therapy study. And this is really a phase 1/2 study where we're going to look at the light dose, 2 doses in 10 to 12 patients. And, you can see here that we're going to enroll patients, 9 to 12 patients, based on the light dose. If everything goes well, we'd like to get up to a 400 joule light energy dose. That's really the goal based on some other studies done in Europe recently. So this was our first patient we just treated a little over a week ago, 2 weeks ago, I guess. And you can see here, I'm placing the balloon in the cavity. You can see the exoscope's above my head here.
Here we go.
And then we're stepping the pedal, and the laser light is now illuminating the balloon. And you can see here on the right, the laser fiber is red, and that's going into the cavity. So, it's kind of neat. And this was the team, Dr. Rains from University of Lille came and visited me in Pittsburgh while we did the surgery. You can see our resident here to the left-hand side and our cool French goggles. So I'm going to summarize here at the end of my talk. I think I'd like to leave some questions if there are any. I think, intraoperative visualization technologies are really essential for glioma surgery. Fluorescence-guided surgery can permit real-time intraoperative visualization of tumor tissue that can be highly diagnostic and permit for more extensive resection. 5-ALA is the only FDA-approved agent for use in glioma surgery. We're looking at newer intraoperative visualization devices. And then intraoperative photodynamic therapy may be the next step forward in the management of these difficult cancers. So going back to the importance of translational research, I think it's extremely important. I think as a physician scientist, you're obligated to translate clinical medicine forward, and you can perform high quality clinical trial research that is considered translational. I do perform benchtop research too, but you don't have to do that as well. And again, your team is really important to your success, and you cannot do this by yourself. So just want to acknowledge all the different people that have helped me through the years here, and love to answer any questions that we have.
Oh, thank you for that excellent and shocking presentation. I'm always amazed by you people that operate these kinds of tumors, especially in the brain, which is so sensitive and so complex.
Yes.
So, yeah, bravo. So, since until we get some questions, I'm gonna take advantage of being the moderator here. So, the first thing is, my first question is, what is the special ability that makes 5-ALA attract specifically to cancer cells? What's the mechanism?
Well, so I think what we think is going on is in glioma cells and also the skin and the bone marrow, the levels of the furochelatase enzyme are lower. So that's why it backs up, and there's greater uptake of 5-ALA in those tumor types, in the glioma tumors and then the skin and the bone marrow. That's really the going mechanism of how this kind of localizes to those areas.
Have you checked, I mean, within the tumor, we have different kinds of cells, and glioblastoma is notorious for their heterogeneity. Does that apply for all kinds of cells? Like, for example, the glioma stem cells, if
Yes.
you know, is there a difference? And
yeah, so we look, there's papers on glioma stem cells and 5-ALA fluorescence. They also fluoresce as well. I think the tumor-associated macrophages are another cell type. If you look at GBM tumors, about 40% of the tumors, 30 to 40%, are comprised by TAMs, and those also fluoresce quite nicely. It's not just the glioma cell; it can incorporate other cell types as well.
So it kind of captures the microenvironment.
That's it. Exactly. Yes.
What we want. And,
that's right.
And you presented something about children, but I was gonna ask it. I was thinking about it, but do we observe the same properties? And since the brain of a child is much more plastic and it's growing at the same time. So
right.
How easy and what would be the differences versus an adult glioma or glioblastoma?
Yeah, that's a great question. So in children, there's been limited series done with use of 5-ALA, but they do, the tumor types do fluoresce. And that's why we're going to do the study. We're going to look at all pediatric brain tumors and really get to understand which of those tumors fluoresce better than others. There's also a pediatric study being done in Europe right now. So they're going to be done in parallel, but I think it'll be important to understand use of 5-ALA. There is some study now too, where 5-ALA is being used as a radiosensitivity enhancement agent as well. So there's all sorts of properties that we're understanding with 5-ALA in addition to visualization that are now coming forward. And the mechanism behind why tumors are more radiosensitive with 5-ALA, it's unclear right now.
Guillermo, I think you are, you can talk with me. I'm mute. You have to unmute yourself.
Did she want to unmute?
Yeah, she has to unmute. I can look it. Okay. Guillermo, I think you can, no. Maybe you can type if you cannot unmute.
Do you want to type the question?
No.
Okay,
Yes.
we can hear you now.
Okay. I'm very, very glad, Dr. Hadjipanayis. From Cyprus, I'm calling. I think we know each other. We talked before. I lost my husband with GPM, and now I'm running the
Your
Facebook
sound is
group.
breaking.
Yes, yes.
Oh,
that's
this is
right.
very, very exciting. Very nice to hear these things. What I want to ask, and Maria knows that too also, how easy is it for Cypriot patients to take part in these clinical trials? Or what can be done for Cyprus to participate in your programs? Is there any collaboration? Could there be any collaboration?
Well, I think that's a great question, Gula. I think we can certainly evaluate patients in the US for surgery. The clinical trials become a little bit of a challenge. But what I would say is we are open to collaboration once the study's done. And, I'd have to kind of find out, I need to understand, what's being done from the neurosurgeon standpoint there. But I hope this is something that could be widespread, and it definitely is something that we're learning can be accomplished in the operating room. So the question is, what kind of benefit will the patients have? So that's what we're learning right
Yes,
now.
and what kind, how easy it is. We have 2 cancer centers only, not brain tumor centers at all in Cyprus. And you are from Cyprus, and there are so many exceptional sciences that we could use. I don't know if you understand what I mean.
Yeah.
If those cancer centers collaborate with you or your center, your university and everything.
Yeah. No, I'd be happy to talk to him. I'd be happy to talk to him.
Yeah, we're working on that, and this is one of the purposes that I was telling.
That's what I want to know,
Hadjipanayis.
Maria. That's what I want to know.
We're
Okay.
trying.
Thank you very much. Thank you.
Yeah, it was a pleasure hearing you, Gula.
Bye-bye. Bye.
Bye.
Right.
So yeah, that's as I was saying before to Costas, this is one of the goals and the wish that through this series we establish collaborations with scientists and expats. Greek, we have a huge Greek community. We have many people that excel in different areas. And I know there's another Cypriot that you can see, Yorgos Zinonos, who's also a neurosurgeon. I don't know if you can hear me now, but hello.
He's from Napa too, I think.
Yeah, he's close from the area. So for context for people, I did my PhD at Pittsburgh, so I have fond memories of people that I know there. So yeah, it's we have to bring these people together and try to help as much as we can, both the research starting from the basic up to the translation up. So yeah, so in terms of the science, I'll go back if nobody else has another question for now. So I'm just curious with regards to what you mentioned at the end, like using the 5-ALA as a means to kill the
residual cells.
The residual cells. Does that target the cancer cells or also other cells of the tumor microenvironment? Like
I think other cells, in the tumor microenvironment as well. That I mean, we haven't shown this yet, but I would expect the TAMs are also targeted in addition to the glioma cells. the good thing is that we don't see much PP9 accumulation in the neurons, which is good.
Oh, that was one of
Yeah.
my next
Yeah,
steps. Because,
yeah.
yeah. So, sorry, I interrupted you, but I was gonna say there's a lot of hype now about cancer neuroscience, how the nervous system, the nervous system
Is related to cancer for sure.
yeah, it's directing and it's being directed by cancer. And in the case of glioblastoma, it's a brain within the brain. So, and in my previous observation, that when you operate, you have to be very careful because you have the nerves and all that.
That's right. Yeah.
So there's no accumulation in the neurons.
No,
or
there's no neuronal accumulation. We'll see it sometimes in reactive astrocytes in and around the tumor, but you won't see distal fluorescence outside of the tumor. That's the beauty.
Okay, so with that regard, so there was a recent publication that they saw activation of brain areas that were far away from the tumor. So when the tumor was active, you got activation of distal brain areas from the Hadjipanayis, I think, lab. So have you ever seen that, like the operating room with this technique? I know you have to image the brain. I don't know if that's
yeah. You know what we've seen, I've seen in the operating room areas that fluoresce adjacent to the tumor, and I wonder why. And then it turns out that that was a tumor there that I couldn't see on MRI scan because I sent it to pathology, and the pathologist confirmed it's a tumor.
But it was a life-saving observation.
Well, I mean, it helps us see it better and take it out, but we can't. That's a rare situation. Most of the time, the tumor kind of is in the vicinity of the fluorescence. So, you know, distal fluorescence, you know, and multifocal GBM is usually, you know, less than 10% of patients.
And I guess one last question.
Yeah.
We don't have anybody else. So, with your experience and with your knowledge, what would you think would be like the next steps that would take us to a more close to a treatment situation? Because GBM is such a abuse, but giving at least a small percentage of hope for this disease is important. So, how would you summarize your view?
Well, I think the residual cells are the problem. So if we could target them better at surgery with something like photodynamic therapy or what other local treatment, you know, that would be helpful. The immunotherapy story has been disappointing, however. It hasn't shown much benefit with GBM in multiple studies. So I really hope that the photodynamic therapy story can, you know, provide us better treatment options. The other thing is, there may be an immunological response as well with the PDT that's been shown in other cancer types, where you can have a abscopal effect to cancer cells because of the PDT-associated immune modulatory approach.
Is it in combination to control both the immune component and the cancer per se?
Yeah. In other PDTs, it's been shown. We don't have any data on 5-ALA PDT yet scientifically. It's only been, you know, reported case reports.
Well, we hope to see more results.
Yeah.
Future and yeah. So it was a real pleasure having you on the series, Costas. And we have to mention that we are organizing a big cancer conference for the first time in Cyprus, and Dr. Hadjipanayis will be honoring us with his presence. So there's more to learn until then. Thank you again.
Thank you, Maria. Thank you, everybody. Really appreciate the chance to talk to you.
Have a lovely rest of your day.
Okay, have a great day.
Say hi to George from me.
I will. Yes, I will. Bye.
Have a lovely day. Thank you.
Take care. Bye.
Bye to everybody.